Okay, so let's talk about anemia. You know that feeling when you get a lab report back, you see that low hemoglobin, and your mind just floods with dozens of possibilities? It can feel pretty overwhelming. But what if I told you there's a simple, systematic way to cut through all that noise and get to the right answer every single time? Well, that's exactly what we're going to build together right now.
Here's our game plan. We'll start with that very common problem, get our definitions straight for exams, then we'll master the MCV-based approach, which is the core of all this. After that, we'll take a look at what the cells actually look like, lock in some high-yield points, and wrap it all up with a quick recap. Sound good? Let's do it. So let's kick things off with a scenario that I guarantee every single one of us has faced, whether it's on the wards or in a practical exam. Right? You get that complete blood count, your eyes go straight to the hemoglobin, and it's flags as low. And for a second, you just freeze. Now what? Where do you even start? That first step you take is so important. It's what makes the difference between a sharp, focused workup and just getting lost. Okay, so before we start diagnosing anything, we need to be crystal clear on our definition. For your exams, what is anemia, really? So at its core, this is the physiological definition you need to remember. It's not just about a number. It's about the consequence. The tissues aren't getting enough oxygen because the blood just can't carry it. That's what causes all the symptoms like fatigue and weakness. Now here's a super important point, and honestly, it's a classic trap for students, especially when you're dealing with kids. There is no single magic number for low hemoglobin. A value that's totally normal for a 2-year-old might be dangerously low for a newborn. It's all about context. And just take a look at how much these values can change. It's pretty dramatic. A newborn starts out with a mean hemoglobin around 16.5, but by the time a child is, say, 4 years old, the average has dropped to 12.0. You see? If you tried to use one single cutoff, you'd be making mistakes all the time. So your first job, always, is to compare the patient's lab value to the normal range for their specific age. All right, so you've confirmed that your patient is actually anemic for their age. Now what? Now we bring out our most powerful tool, the MCV-based approach. This is the simple, universal framework that we all use to classify anemia. It's basically a 3-step process. First, look at the MCV. That tells you the average size of the red blood cells. Then, based on that size, you put the anemia into one of 3 buckets: microcytic for small cells, normocytic for normal-sized cells, or macrocytic for big cells. And from there, each bucket has its own clear diagnostic path to follow. Simple as that. Let's dive into that first bucket, microcytic anemia. This is when the MCV is low, usually under 80. The red blood cells are just too small. This flowchart right here, this is your roadmap. Okay, so follow the logic. The first big question is, what's the reticulocyte count? That tells us if the bone marrow factory is trying to compensate. If the count is low, it means the factory is not responding. So your next move is to check iron studies. If you see low iron and a high TIBC, which you can think of as how hungry the body is for iron, then bingo, that's classic iron deficiency anemia. But if the iron studies are normal, you have to think about something else, like thalassemia, and you'd confirm that with a test like HPLC. Now let's move on to the next bucket, normocytic anemia. Here, the MCV is normal, somewhere between 80 and 100. The cells are the right size, but for some reason, we just don't have enough of them. And are you noticing a pattern here? The first thing we check is, once again, the reticulocyte count. If it's high, it tells you the bone marrow is pumping out cells like crazy. Why? Because they're either being lost, like in a hemorrhage, or they're being destroyed too early, which is hemolysis. But if the count is low, it points back to a production problem, things like anemia of chronic disease, or maybe even a very early iron deficiency. And finally, our third bucket, macrocytic anemia. Here, the MCV is over 100, so we're dealing with abnormally large red blood cells. This often points to problems with cell maturation, like what you see in B12 or folate deficiency. And just like the others, there's a clear algorithm to follow. Okay, we've gone through the flowcharts and the logic. But now, let's connect those numbers to what you'd actually see under a microscope. This is where it all starts to click. A classic exam question is telling the difference between iron deficiency anemia and beta thalassemia trait. They're both microcytic, so how do you separate them? This table gives you the clues. The key player here is often the RDW, or red cell distribution width. In iron deficiency, the RDW is usually high because the marrow is sputtering, making cells of all different sizes. In thalassemia trait, the RDW is typically normal because all the cells are small, but they're uniformly small. And this is what that actually looks like. On the left, with iron deficiency, see how the cells are small and pale with that big central pallor? Classic microcytic hypochromic picture. Now look to the right at the thalassemia smear. You see a lot more variety in the shapes, and you can spot those distinct target cells. Seeing the smears really helps these concepts stick. All right, let's switch gears. Time for some rapid-fire, high-yield points. These are the absolute must-know takeaways for your exams. First, this number, less than 80 femtoliters. Burn it into your brain. When you see an MCV less than 80, your mind should immediately jump to the microcytic anemia flowchart. Iron deficiency, thalassemia, that's your world now. Second, the reticulocyte count is your best friend. It's the single most important initial test to figure out if you're dealing with a production problem or a destruction problem. A low count means the bone marrow factory is failing. A high count means the factory is working fine, but its products are getting lost or destroyed. And third, don't you forget the RDW. This is a huge exam favorite. A high RDW, what we call anicytosis, points you strongly towards iron deficiency. A normal RDW in a patient with microcytic anemia should have you thinking about thalassemia trait. It's a fantastic clue. Okay, we have covered a ton of ground. Let's boil it all down into one simple, actionable summary that you can use on the wards, starting tomorrow.
Here it is, your 4-step plan. Step 1, confirm it's actually anemia using age-specific values. Step 2, classify it using the MCV. Step 3, check the reticulocyte count to see how the bone marrow is responding. And step 4, follow the right algorithm to nail down the specific cause. That's it. So, I'll leave you with a final thought to ponder. Using this exact framework, think about the population where you practice. What are the common nutritional issues or genetic factors? Which type of anemia are you most likely to see? And how would you use these steps to prove it? Thanks so much for joining me.